Hi everyone, welcome back to my YouTube channel. I have created part 3 of calendar year 2023 Medicare Physician Fee Schedule Final Rule to cover some more of the takeaways from this final rule. Let's get started. With respect to rural health clinics and federally qualified health centers, let's talk about chronic pain management and behavioral health services. CMS is finalizing the addition of chronic pain management and behavioral health integration services to the rural health clinics and federally qualified health centers specific general care management HCPCS code G0511, which aligns with changes made under the physician fee schedule for calendar year 2023. Since the requirements for the chronic pain management and behavioral health integration services are similar to the requirements for the general care management services furnished by rural health clinics and federally qualified health centers, which are the current services for which rural health clinics and federally qualified health centers can use HCPCS code G0511. The payment rate for HCPCS code G0511 will continue to be the average of the national non-facility physician fee schedule payment rates for the rural health clinics and federally qualified health center care management and general behavioral health codes, which are CPT codes 99484, 99487, 99490, and 99491, and PCM codes, which are CPT codes 99424 and 99425. Payment will be updated annually based on the physician fee schedule amounts for these codes, which is how these updates are made currently. Telehealth services. CMS announced that they are implementing the telehealth provisions in the Consolidated Appropriations Act of 2022 via program instruction or other sub-regulatory guidance to ensure a smooth transition after the end of the public health emergency. The Consolidated Appropriations Act of 2022 extends certain flexibilities in place during the public health emergency for 151 days after the public health emergency ends, including allowing payment for rural health clinics and federally qualified health centers for furnishing telehealth services as distant site practitioners under the payment methodology established for the public health emergency, allowing telehealth services to be furnished in any geographic area and in any originating site setting, including the beneficiary's home, and allowing certain services to be furnished via audio-only telecommunication system. Please note that mental health visits can be furnished virtually on a permanent basis. The Consolidated Appropriations Act of 2022 also delays the in-person visit requirements for mental health visits via telecommunications technology, including those furnished by rural health clinics and federally qualified health centers, until 152 days after the end of the public health emergency. Confirming technical changes to the in-person requirements for mental health visits. CMS finalized confirming regulatory text changes in accordance with Section 304 of the Consolidated Appropriations Act of 2022 to amend paragraph B3 of Title 42 Code of Federal Regulation 405.2463, what constitutes a visit, and paragraph D of Title 42 Code of Federal Regulation 2469, federally qualified health center supplemental payments to include the delay of the in-person requirements for mental health visits furnished by rural health clinics and federally qualified health centers through telecommunication technology under Medicare until the 152nd day after the COVID-19 public health emergency ends. Specified provider-based rural health clinic payment limit per visit. Subsequent to the publication of the calendar year 2022 Physician Fee Schedule Final Rule, which implemented changes to the rural health clinic payment limit as required by the Consolidated Appropriations Act of 2021, interested parties requested clarification regarding the timing of cost reports used to set the rural health clinic payment limit. CMS finalized the clarification that a 12 consecutive month cost report should be used to establish a specified provider-based rural health clinic's payment limit per visit. CMS believes 12 consecutive months of cost report data accurately reflects the cost of providing rural health clinic services and will establish a more accurate base from which the payment limits will be updated going forward. Clinical Laboratory Fee Schedule or CLFS. In accordance with Section 4B of the Protecting Medicaid and American Farmers from Sequester Cuts Act, CMS is finalizing certain conforming changes to the data reporting and payment requirements at Title 42 Code of Federal Regulation Part 414 Subpart G. Specifically, CMS is finalizing revisions to 414.502 to update the definitions of both the data collection period and data reporting period, specifying that for the data reporting period of January 1st, 2023 through March 31st of 2023, the data collection period is January 1st of 2019 through June 30th of 2019. They are also finalizing revisions to 414.504 Paragraph A1 to indicate that initially data reporting begins January 1st of 2017 and is required every 3 years beginning January 2023. In addition, CMS is finalizing conforming changes to the requirements for the phase-in of payment deductions to reflect the amendments in Section 4B of this law. Specifically, they are finalizing revisions to 414.507 paragraph D to indicate that for calendar year 2022, payment may not be reduced by more than 0% as compared to the amount established for calendar year 2021, and for calendar years 2023 through 2025, payment may not be reduced by more than 15% as compared to the amount established for the preceding year. Additionally, after consideration of public comments and further analysis, CMS is finalizing an increase to the nominal fee for specimen collection based on the Consumer Price Index for all urban consumers or CPIU. Therefore, for calendar year 2023, the general specimen collection fee will increase from $3 to $8.574, and as required by PAMA, they will increase this amount by $2 for those specimens collected from a Medicare beneficiary in a SNF or by a laboratory on behalf of a home health agency, which will result in a $10.57 specimen collection fee for those beneficiaries. In addition, CMS is finalizing a policy to update this fee amount annually by the percent change in the Consumer Price Index for all urban consumers or CPIU. CMS is also finalizing their proposals to codify and clarify various laboratory specimen collection fee policies in Part 414, Section 523, Paragraph A1. This is because the policies implementing the statutory requirements under Section 1833, Paragraph H3A of the Act for the laboratory specimen collection fee, which are currently described in the Medicare Claims Processing Manual, Publication 10004, Chapter 16, Section 60.1, did not have corresponding regulations text, and some of the manual guidance is no longer applicable. Lastly, in light of questions CMS has received from interested parties, they are finalizing as proposed to codify in their regulations and make certain modifications and clarifications to the Medicare Clinical Laboratory Fee Schedule or CLFS travel allowance policies. CMS is finalizing the addition of Part 414, Section 523, Paragraph A2, payment for travel allowance to reflect the requirements for the travel allowance for specimen collection. Specifically, in accordance with Section 1833H3B of the Act, they are finalizing to include in their regulations the following requirements for the travel allowance methodology. 1. A general requirement. 2. Travel allowance basis requirements, and travel allowance amount requirements. Medicare Ground Ambulance Data Collection System. CMS is finalizing a series of changes to the Medicare Ground Ambulance Data Collection System. First, CMS is finalizing their proposal to update their regulations at Part 414, Section 626, Paragraph D1 and E2 to provide the necessary flexibility to specify how ground ambulance organizations should submit the hardship exemption request and informal review request, including to their web-based portal once that portal is operational. Second, CMS is finalizing their proposed changes and additional clarifications to the Medicare Ground Ambulance Data Collection Instrument. The changes and clarifications aim to reduce burden on respondents, improve data quality, or both. CMS grouped these changes and clarifications into four broad categories: editorial changes for clarity and consistency, updates to reflect the web-based system, clarifications responding to feedback from questions from interested parties and testing, and typos and technical corrections. Origin and destination requirements under the ambulance fee schedule. CMS is finalizing their interim final policy that the expanded list of covered destinations for ground ambulance transports was for the duration of the COVID-19 public health emergency only. These destinations include, but are not limited to, any location that is an alternative site determined to be part of a hospital, critical access hospital or skilled nursing facility, community mental health centers, federally qualified health centers, rural health clinics, physician offices, urgent care facilities, ambulatory surgical centers, any location furnishing dialysis services outside of an end-stage renal disease or ESRD facility when an ESRD facility is not available and the beneficiary is home. When the COVID-19 public health emergency ends, their regulations will reflect the long-standing ambulance services coverage for the following destinations only: hospital, critical access hospital, SNF, beneficiary's home, and dialysis facility for an end-stage renal disease patient who requires dialysis. In addition to these long-standing covered destinations, rural emergency hospitals or REH will also be an allowed destination in accordance with the Consolidated Appropriations Act of 2021, effective with services on or after January 1st of 2023. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.